Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Welcome, everyone, to October's Family Medicine Grand Rounds. My name's Doug Archibald, and I'm the Director of Research for the Department of Family Medicine, and I'll be today's host. Today, we have two medical student presentations. These medical students have worked with two of our family medicine clinician investigators, and they are Rohan Singh and Shahir Nadeem. Unfortunately, we did have a message just this morning that Shahir is unable to attend, so we're just trying to find out if his supervisor will actually be able to present in his stead. Nonetheless, we'll begin with our first student, and that is Rohan Singh. Rohan is a second-year medical student here at the University of Ottawa, and after completing his honors specialization in interdisciplinary medical sciences at Western, he's joined us here at the University of Ottawa. And during his undergraduate, Rohan had research community service learning and is now using this knowledge to study campus community engagement. So this summer, he has been working with David Buetti and also our DFM's Claire Kendall on this project. And I guess without further ado, then I will turn the floor over to you, Rohan.
Good morning, everyone. Thank you so much for joining us today. Hopefully you're enjoying that first, second, third cup of coffee already. So we're excited today to present some findings from our qualitative study that explores how stakeholders of community campus engagement projects evaluate their health outcomes. So just a bit, but first a bit about us. My name is David Woody. I'm an assistant professor of program evaluation at the University of Montreal School of Public Health. And I'm joined by Rohan.
Yeah, and as Dr. Archibald had mentioned, again, my name is Rohan Singh. I'm a second-year medical student here at the University of Ottawa. I first joined Dr. Kendall's research team over the summer as a student researcher and have just been carrying on this project over the school term.
When we prepared our presentation, we focused on 3 key learnings. So the first one was define community and campus engagement and and its relevance to family medicine. Also identify some challenges and facilitators to effective evaluation of community campus engagement impact on health, or CCE, and discuss some implication of our study for family medicine practice. A bit of context, medical schools and municipalities hold a shared responsibility to ensure they're both socially accountable to the health needs of their community, of the community they serve. And this accountability goes beyond training high quality healthcare professional. It also involves engaging with and also understanding the challenges faced by their local population. And in this context, we would like to present community campus engagement as a promising approach for medical schools to actually contribute to improving community health outcomes. But what exactly is CCE? You might wonder. Well, CCE, or community campus engagement, has no really single accepted definition in the literature, but usually refers to partnerships, collaboration between medical schools or an academic institution with communities and often government stakeholders to address community identified needs. So across the literature, there's usually 3 characteristics that stands out. The first one is it fosters collaboration. Second, it emphasizes reciprocal relationships where all partners benefits, and also it focuses on creating meaningful, sustainable impact on community health. Some forms of community campus engagement. Some of the key forms include, for example, service learning, where medical students can gain hands-on practical experience through community service. We can think about, for example, health screenings at shelters, where it will be a win-win situation between medical students gaining practical skills, but also the community receiving services. So it's a reciprocal relationship and also meaningful for both of them. Community-based research, where community members and researchers will work together on health issues, such as identifying local factors affecting asthma rates, for example. And the third one that is common in the literature is civic engagement, which involves many types of activities to address broader social determinants of health, such as advocating with communities, for policy changes, improving health equity. So each form offers family doctors, students, opportunities to contribute their expertise and improve community health outcomes. Now, what about the gap we're trying to bridge here? Well, CCE is gaining a momentum right now. It attracts greater investment, greater interest from funders, medical schools, and community partners. And with that interest also comes a desire to I don't know if desire is the right word, they want to understand better, have evidence of their impact. So we're putting a lot of resources, time, investment. What does it provide communities with? Does it provide communities with to which extent it provides communities with concrete health benefits? Well, what we're seeing in the literature is that there's not much about that. So there's still a limited research demonstrating the full scope of CCE's impact on health outcome, which underscore a critical need for more research, but also for robust program evaluation. So what is evaluation? Well, it seeks to assess whether the time, the resources we're dedicating to CCE projects are actually resulting in tangible, concrete impacts. So by doing program evaluation, we can either refine some intervention, guide resource allocation, and also better understand, amplify the long-term benefits of CCE. So while many CCE projects are likely to perform internal evaluation, the findings are usually not published. They're often unpublished, so which can limit or understanding of CCE's impact. So this also raised an important question, to which extent CCE's project are actually being evaluated? What are the practices used to understand the impact of CCs on health? And this is where our study, well, the Rohan study, comes into play. Rohan study, as you mentioned before, is also part of a larger CIHR research project led by Claire Kendall, and for which I'm co-investigator, that aims to evaluate how and to what extent community campus engagement impact population health outcomes in Ottawa and Thunder Bay. And within this sub-study, we were interested in understanding at least two questions. The first one is, how are CCE projects initiative currently evaluating health outcomes, and what specific tools, method are they using? And also, what are the challenges, if any, they face in evaluating the health outcomes of their initiative? So I'll let now that Rohan, you can take over. Thanks.
Good. Thank you, David. So I'll be speaking a bit more now about how our study was carried out and our initial preliminary findings. So we elected to use an exploratory qualitative study design for this topic, which we deemed to be appropriate given the small volume of current research on community campus engagement that David had mentioned earlier. As the measurement of engagement impact is poorly understood in published literature, we hoped to uncover what tools are being used in the field and what the associated successes and or drawbacks of these tools could be, rather than to provide much of a causal explanation. So the sampling method that we chose to use was purposeful sampling for interview participants. This is because our study hoped to draw on the unique experiences of community campus practitioners. So we sought out those who had been involved in CCE from both the community and campus side of the partnership. Interview participants were also then able to direct us to previous partners that they themselves had worked with in the field, allowing us to learn from their experiences as well. As this was an exploratory study, semi-structured interviews were used to better understand the unique experiences of each interview participant, and multiple coders were used to interpret interview data and generate themes for the produced codes. And again, like any disagreement in coding or theme generation, which occurred between the two coders, was resolved by a third party there. So to discuss some of our preliminary findings here. So from our interviews, we found that less than a third of CCE practitioners had actually ever measured the impact of their engagement in any community campus engagement projects they had been involved in. This was incredibly surprising, as honestly entering into the project, I'd assumed that most practitioners would be measuring their impact. However, seeing how rarely this actually happens led us to explore the barriers and facilitators of measurement. This lack of measurement is also surprising when put into the context that nearly all of our interviewees agreed that community campus engagement does have an impact on population health, yet only less than a third of these practitioners had the opportunity to try and measure that. So for those who were able to engage in measurement, their measures focused primarily on process outcomes related to relationship building or immediate health outcomes, which was mostly seen in engagements which aimed to support mental health initiatives. So of the engagements which did measure impact, the tools that were most commonly used are listed here. So surveys were the most popular choice, with few groups choosing to do both baseline and post-implementation surveys. However, as many engagements did not utilize baseline surveys, it was difficult for them to accurately assess the impact of their engagement. Focus groups and follow-up key informant interviews were also commonly used. Utilizing these loosely structured conversational analysis techniques allowed practitioners to gain a deeper understanding of how their initiatives impacted community members and community service delivery. What we see from most of the methods used is a focus on qualitative results without much use of a standardized or objective impact measure. One tool which we had heard about being developed in our interviews is the Knowledge Engagement Impact Assessment tool coming from the University of Calgary. So this tool provides a quantitative measure for researchers to evaluate their work. However, this matrix focuses heavily on the pre-engagement phases of community campus engagement, with heavy weight being attributed to relationship building and trust, rather than focusing on the impact of the community partnership. Regardless, many interviewees had noted that if they had been provided with the tools and avenues to measure engagement impact, then they would have happily done so. However, this just wasn't the case in their experience. And the utilization of an appropriate objective evaluation tool would allow for the establishment of CCE best practices, allowing all CCE practitioners the opportunity to integrate beneficial techniques into their own practice, which they can learn from other practitioners utilizing a similar assessment tool. So now to talk about some of the primary challenges that were faced by CCE practitioners when attempting to evaluate the impact of their engagement. So one of the first challenges we discovered that stakeholders were facing were short project timelines, which precluded follow-up measurement activities. So as we can see from one of the quotes listed here on the slide, one of our interviewees had projects which lasted a semester or approximately 4 months. And once the deliverable for that project was produced, they would then move into the next project cycle without there being any time to measure the impact of the first deliverable. So having the engagements set for such a short time period makes it difficult for there to be any measurable change in the community to begin with, as well as it not providing much time for that measurement to occur. With the time period being so minimal, the focus is much more set on delivering the intervention itself rather than having much time to measure the impact of that intervention. Another challenge many stakeholders experienced was tracking how their community-based research was being utilized to inform future study and action. And this is illustrated by one of our interviewees who worked on a Parkdale heat registry, which tracked the hottest areas of the Parkdale region so that volunteers could go visit unhoused individuals in those regions during heat warnings and heat waves and ensure that everyone had access to water stations and hydration. This project was presented to the City of Toronto, who then later decided to start an analogous project themselves, which the initial researchers only became aware of due to their sustained partnerships with the Parkdale Activity Recreation Center. While this is an issue faced by all researchers, where it's difficult to know how your research is going to be utilized in the future and how those findings will be interpreted by other parties, this challenge is particularly salient in the field of community campus engagement, where these findings are often used to inform community-wide interventions and policy decisions, which impact large groups of people very quickly. A third barrier that we heard about from our interviewees was that of CCE projects not having the capacity to measure the impact of their engagement. As noted by one of our interviewees, a lot of CCE projects tend to be experimental or pilot projects, which are supplied minimal resources to begin with. So there's a significant lack of internal capacity to carry out the initiative, let alone to measure its impact as well. This is also where a lack of evaluation expertise might come into play, where many of the CCE practitioners may not have the skill set, expertise, or tools to appropriately measure the impacts of their engagement. From other interviewees, we also heard a purposeful hesitancy to measure impact, as they felt that any additional resources that they had were actually better spent serving the community rather than measuring the impact of their engagement. In our view, this displays a little bit of a misunderstanding of the importance of impact measurement. Establishing proper evaluation techniques can encourage further CCE initiatives with increased funding and rigor, improving opportunities for future projects and bettering population health outcomes in the long run. So while for that one project itself, resources might be better delivered to the community, it is prohibiting future CCE work and prohibiting future funding of additional CCE projects. And so talking about funding, the fourth barrier here that we heard frequently from our interviewees was rigid funding structures. So as we discussed, short-term projects are not able to fully capture the impact that CCE has on a community, and short-term funding models are not providing community campus engagement with the resources required to show its benefit. I think we're all quite familiar with how long it can take to change population health outcomes, and the focus on short-term funding models is not really aligned with that reality. And so interviewees noted that often what they measure is actually dictated by the funding bodies, as they want to continue to receive funding for their project, and so they're fulfilling the criteria set out by those funding agencies. However, these criteria are typically decided quite unilaterally by the funding agency without taking into consideration the unique health needs of the communities being served. So providing funding structures which prioritize population health would better support CCE initiatives and provide avenues for meaningful measurement. So to sort of tie together a lot of these barriers that we had discovered through our interviews, we can say that CC initiatives rarely include formal evaluation of their impact on community health outcomes, as this evaluation is hindered by multiple barriers, including limited resources, time constraints, and a lack of evaluation expertise. And evaluation of CCE is quite important, especially in these initial phases where it is still a growing and establishing field, as we need to better understand the role that this collaboration plays in population health to better direct future engagements. Again, it's important for us to be able to publicize this knowledge, be able to share with other CCE practitioners the importance of collaborating with community members and working in a community-led manner to identify population health challenges. So overall, the exploratory nature of our study, given the exploratory nature of our study, more rigorous research is needed to fully understand specific evaluation practices that are currently being used in CCE. As discovered, there's still much to learn about how these initiatives are assessing their contributions to community health. And this understanding will help us identify best practices and develop more effective strategies for measuring and improving CC initiatives in the future. And so how community campus engagement sort of plays a role now in healthcare provision and in the field of family medicine. So as healthcare providers, and more importantly, as members of our communities who live, act, and draw on the resources that were provided by our communities, there is a responsibility to provide not only individual healthcare, but also to address population health outcomes. As physicians, especially, there are opportunities out there to uplift community health as a whole. And yet there tends to be quite a bit of a focus on individual health rather than working to address population health outcomes. But when engaging in population health research, it's important for this research to be guided by community identified priorities and completed in collaboration with the community. We heard time and time again from our community interviewees how important it was for them to be able to have a space to speak with their physicians, to identify what the challenges in their communities are, so that the interventions could be appropriately targeted towards the needs of the community, and to ensure that those interventions actually would be uptaken by the community and be presented in an acceptable manner. Research should also be designed with the intention of measuring impact from the start. So those clear expectations should be set when deciding on project timelines, funding timelines, and all those initial organization measures. And funding should be provided to facilitate this, again, ideally with more of a flexible funding structure that we talked about earlier. I know that a lot of us are in the position where we're often applying for funding for research, but if we are ever so fortunate to be the ones to provide funding, I think it's important to keep this in mind that funding should be flexible to allow for community identified needs to be a key metric there. And also it's important for long-term relationships with community partners to be built to really help establish trust in the healthcare system. I think that when we let our community members sort of identify what their needs are and what their challenges are, this goes a long way in repairing a lot of the trust that's been broken with a lot of marginalized communities, allowing our community partners to sort of be the ones to lead us, to show us where the help is needed, and then allowing physicians to sort of meet that gap, I think is a very strong way to build longstanding relationships with our community partners. So thank you so much for your time this morning. Me and David here are happy to answer any questions that might arise. Additionally, our contact information is here on the screen if any questions arise later in the future and you want to reach out to us. But thank you so much for sharing your morning here with us.
Rohan and David, thank you so much for that presentation. A lot of great work underway. Actually, I'd like to start the conversation off if I could. When you spoke of the challenges that stakeholders have, timelines, resources, I think this is common in this area. You know, when you're looking at outcome evaluations, this is difficult, and really pleased to see that you had multiple means of trying to look at impact. Everything from the focus groups, and I was really interested in this. I'm assuming this instrument from Calgary, how that may help as well. But often I find a framework that actually is good for this, where you have where you have these challenges. It's something called the eco-normalization framework by Dina Hamza and Glenn Regehr. And it really looks at helping to look at how these projects and programs, or sorry, projects within a program such as the CCE, you know, how it can move beyond the present, like, you know, how it can, looking at longevity, looking at sustainability. So that's something worth looking at, I think, you know, in terms of helping to frame an evaluation such as this. Actually, my question actually came up with Rohan, 20. You had 20 participants, and just wondering, how is it you determined 20 is the number? I know this is often a question that qualitative researchers have. You know, there's this sort of, there's a conversation going on right now between saturation, you know, as determining determining a sample size for qualitative studies, also for data, you know, when you have enough, versus sufficiency. And, you know, just wondering if, you know, 20 was determined to be sufficient for getting the data that you needed.
Yeah, so I think, like, first I'll actually touch on what you had talked about, the like eco-normalization framework I think you mentioned, and longevity of projects. I think that's something important to mention, as well as when some of these engagements are put in place, a lot of communities can rely on these services that are being administered by the institution. However, once funding cycles are up, or once professors leave those positions or physicians leave their positions, these services can often then be terminated that communities were relying upon. So we found a few instances where community members themselves took it upon themselves to continue those engagements and that service delivery.
Wonderful.
However, then it became from a volunteer standpoint, and they're putting in a lot of time and resources to ensure the health of their community when they're not being recognized or compensated for that anymore. So ensuring longevity of an intervention is definitely a challenge in a lot of these spaces. But then to touch more on the methodological side of things and our interview participant number. So the first challenge, I guess, was that, as mentioned, like CC is a smaller field, and so it was difficult for us to locate that many practitioners. But luckily, I think 20 was sufficient, as when coding through the interviews, we found a repeated pattern that once our themes were established, we weren't coming up with any new codes related to impact measurement. We were seeing a lot of the same ideas repeated by interviewees. And so we had done sort of like multiple iterations of coding where during the final few stages, we noticed that we weren't generating any codes that hadn't been generated beforehand. So we thought that was sufficient, as we had sort of repeated ideas being shown to us, and we used those to sort of form our themes there.
Thank you.
And,
Claire.
yeah, Claire.
Good morning. Yeah, really nicely done, Rohan. I'm super impressed. I thought your presentation style was very smooth, and clearly you know your area really well. So congratulations on that. I have two comments. I guess the first, in terms, like, this was super interesting for me. I'm the chair of the Department of Family Medicine, and you know, we want to do things and then I think really understand the impact. So I was like really surprised at your findings, and I think that just illustrates a huge, you know, gap in terms of who's evaluating and who's not. But looking, I see Claire Kendall on the screen. So I think we've had a lot of discussions about collecting sort of what I'd call the routine data, and then having it in a way from a community basis that then you're going to have measures and things that you can look at. So I'm just wondering about that aspect of it, because if you had, you know, your community-based data in the same way that we have our hospital administrative data, but it was basically community administrative data that was routinely collected, then you would, I would think you would be able to actually build in the evaluation, even if it was a short time frame, just on the basis of that. And that would make the assumption also that then there's some infrastructure or funding that's going to support that. My second thing then leads into that. It's really about the, you know, a lot of this is very public health, or I guess would have like has so much of an overlap with public health. And I think the work that you're doing, again, is strengthening in our area that connection between family medicine or a university and public health department. And I'm just wondering, did that, like that seems to me, again, it's about building that sort of ongoing, let's say, infrastructure upon which to then do evaluations of, because it's very heterogeneous in terms of your interventions, but it's all about, like, I think from a health point of view, relevant measures in the community. So I guess data, and if you had kind of community administrative data routinely available, and then public health, university kind of connection and strength of connection coming out as a signal at all.
Yeah, so on the first point of the publicly available data or routinely available data, we did have comments from some of our interviewees of, we asked, like, if you were to recommend a way to measure this impact, I guess, like, how would you do so? And there were mentions of relying on publicly available data. Someone had mentioned using, like, Government of Canada census data, but again, the drawbacks of that not being entirely community specific or having those 4-year intervals where you might need data more frequently. So there was a desire expressed for more available, routinely collected data that is a bit more community specific. And I think that could be helpful in so many different spheres of life and be used by so many different researchers. So I think that would be beneficial to multiple people in the space. And then secondly, on the talk of, like, relation between public health and the institution, I think there's a lot of, I guess we've discussed so much, like, within the Faculty of Medicine or within literature as a whole, like the importance of preventative healthcare and the role that different healthcare practitioners can play in not only reacting to healthcare that is occurring within our population, but being able to prevent like chronic disease and prevent injury within our populations. And I think partnering with our communities early on to understand the risks of health that they face and addressing it through that public health lens is such an important aspect that any healthcare practitioner can engage in and isn't really siloed to the field of public health itself, and it's something that we all can learn from.
I just was going to ask a question. I mean, and I commented a question just hearing Claire's questions, you know, and how relevant they are to many of the conversations we're having around the use of community data. How can we use them? Calgary does have some great tools that we can be leveraging. But I also just really wanted to echo what an amazing job both David and Rohan had done, but especially Rohan at a time of transition when David was taking on his new faculty appointment. And I had a question that I wanted to ask Rohan, which is, you know, you came into a very unwieldy project with lots of movement as a student working virtually, right? And I'm just curious, I mean, we don't have a ton of people left around the table. I think people signed off after the presentation, but like, what are the tips you would have for other research teams embedding a medical student? Like, what worked well for you? What allowed you to thrive so well as a person, like, that we can be sharing with future?
I think like something that I had really appreciated from working with the research team over the summer and like wasn't something I had expected at all entering in was sort of like allowing me to identify like what my interests were and then working towards that. I think like that wasn't something I was used to in previous research experiences. I was much more like used to entering a research team that had preset objectives that they wanted me to work towards that were a bit more rigid. And so I really appreciated that opportunity to explain what my interests were, sort of develop research questions that I was interested in, and then spend my summer like working towards those goals that were a bit more like self-identified and aligned with like my motivations more. So I think like that was very helpful, especially for medical students who are trying to explore different fields, like allowing them that more flexibility and being able to approach different questions and explore their interests that way. I also think that there was like a good amount of like team support there as well. I think like research isn't something that all medical students have such a heavy background in. So I really appreciate the like frequent team meetings and check-ins that I was able to sort of draw on the expertise of the entire research team. There's a lot of very, very like excellent and experienced people like working with Dr. Kendall here. So it was very helpful to draw on everyone's experiences there as well. But yeah, I think the main thing being like allowing the student to identify what their interests are and being able to allow them to work towards those.
Rohan, thank you very much. Obviously, this was a very successful summer research project, and there's going to be great things that are going to come from this larger study. So congratulations, well done. Thank you everyone for tuning in today. As you can see, it's a bit of an abbreviated grand rounds this morning as we just had the one presentation. So thank you all for attending.